Thanks, Maddie.
No worries, guys. Hey, guys.
Hello.
Good evening. Hopefully you had a good Easter.
Likewise. Thank you, and you too.
Thank you.
Still coming in? Oh, they're all killing me on the phone. Okay. Ravi, how are you, mate?
Good, good. And yourself?
Good to see you. Good to see you. Another interesting day, huh? Have you had a busy day?
No, I actually had the vaccine yesterday, and I'm not. I had to stay at home. I wasn't feeling very well.
How does it feel?
Are you feeling all right? Like no fever?
Pretty bad. I couldn't work at all.
Oh, really?
Yeah, I don't know.
Maybe you've been vaccinated? You've been vaccinated?
Not at the moment. I'll wait until I get more I see how everyone else goes. I'll let everyone else jump first. We're lucky we're in Australia.
Yeah, it's true.
This won't be recorded, okay? Oh boy, oh boy. It's all coming in. We're just waiting, huh? It's all coming up.
Yeah.
So,
Any questions to ask? You're most welcome to ask.
I know about the course that's in July, is it?
1st July. We're getting quite a few participants now signing up. The first lot of lectures I'm recording as we speak. I mean, on special lectures. So you will get lectures and be 2 days of strong dialogue. So you have a lot of your lectures beforehand that you go through, understand. And then there's a FaceTime in terms of online learning with me. And then you come to theirs. It's a very strong dialogue of discussion of cases and lectures, and if you don't understand, you go through and make it understand. So it's a very intense learning procedure. It's not just one of those easygoing diplomas. You actually be very aware of. You become a very good dentist, I can assure you. You think about the possibilities before you touch. And this is what these seminars are about. The seminars are about to make you think before you actually, treat the patient. Sit back. I mean, most of the problems I have is that patients coming in, refer, otherwise, they think I'm going to jump in their mouth and just fix the problem. I'm sure Maggie knows what I'm talking about. They tell you the story, and it's an art to listen to the patient. Now, you need to learn that art. It's not about getting something and getting a quick mark. I know the answer. No, it's about learning new ways of doing it, and that makes your life and your practice much more easier. I've treated some very complex cases, and complex cases also are complex patients. So you need to manage the patients, about patient management. They all go together. I mean, I think maybe I was talking to Derek once, and we should have a consult together in terms of how do we talk to the patient, how do we get things organized. That's really important. Okay, we got all the participants online. Can we start? All ready to go? Okay.
Yep. Well,
welcome to the college. I think this is webinar number 10 or seminar number 10, and I welcome Dr. Mehdi Rahimi. He's a adjunct associate professor in endodontics and Charles University. Thank you, Mehdi, for joining us.
Thank you for having me. Thank you.
Always a pleasure. Always a pleasure. And I've worked with Mehdi for the last, how long have you been in endodontics, Mehdi? About 15 years?
10, 11 years.
You make it 15, makes it better, like.
Yeah. Probably a bit more than 10 or 11.
It's my endodontist. So, I've seen known Mehdi for a long time, and I do sincerely appreciate your input and your skills, your critical thinking skills, and I really like that. So in many ways we work together and we talk together about patient management. So often we'll say to Mehdi, I want to know the prognosis of his teeth, and if things are failing, what do we do? So this is an important part of the discussion, because when you're restoring major reconstructive cases, you need to understand what can go wrong and what happens when things go wrong. So it's called contingency planning. The important part of this simple picture tells you a story is the patient comes with dislodged crown. So I need to ask myself a lot of questions in terms of what are my treatment options, and what is the patient's wishes, and what will be the long-term and short-term options for this patient, and patients will be much aware of it. And actually, you don't talk to the patient while they're sitting down because they won't hear you. You actually stand them up, eye to an eye, knee to a knee, and you listen to your patients because they will tell you the story. They will tell you how this crown got dislodged. Now, first impression, we might have a root fracture. That's possible. My other impression is there could be an under canal that's probably missing. That's not the problem at this stage. There's a dislodged crown. We're going to talk about how do we fix it. Do we take this crown out or do we restore a tooth? And a lot depends on a number of factors, and I'll come into it, that will make us understand. One thing that I'm looking at this case is this tooth is encircled between two vital teeth. So there's been, if the crown is dislodged, there must be a reason. Okay, this was the end tooth, that would be a different question, wouldn't that be, maybe? It would tell a different question. Because it's within the two sound teeth that's bounded, it makes me think otherwise. And I feel much better. I get this warm, fuzzy feeling that you might be able to save the tooth. Let's move on. So what we're looking for, and when teeth are more from fracture, but the question arises that if immediately it's your first impression to take this tooth out for an implant, so why save this tooth in the first place? So, usually patients say, I want an implant, and I understand that, but I'd like to know, okay, that's the find out why we're saving the teeth, and it's useless to talk about it. Might as well take the implant out, tooth out, and place an immediate implant or to do some internal graft, honestly. But that's not really what we're talking about today, because patients, he's about 45, you're looking at the patient's whole lifespan, and implant is always a possibility for later, and maybe we should think about saving it too. So you talk about the patient, about the biological cost, you talk about the financial cost, and you talk about many things. Many, what else would you consider in this case, for instance, when you get the situation really stressed?
Well, I think first we need to look at the amount of remaining tooth structure left. We need a clinical image of this tooth. Of course, it doesn't look like there are any periodontal factors involved, but endodontically, I'll be looking at the amount of sound tooth structure above the gingival margin, if you like, or the crestal bone. And I suppose that would make a big difference because we're looking at a two-dimensional image here. We haven't really seen it in a clinical images of it to get a better idea of what's there. And certainly, what I'll be thinking about is the future of an implant in this region anyway, 6 to 10 year survival rate, or at the moment, if you want to call it success rate of dental implants in this region are lower than everywhere else in the mouth. And this is all evidence-based literature at the moment. And the other thing that I'll be thinking about is, okay, if the 6 to 10 year survival rate is lower in this region, in the high 70s, low 80s, is what we're looking at. Can I, with what I offer the patient, with a good restorative dentist, give them a comparable outcome? Because there's always, as you said, an opportunity for them to have a dental implant down the track. And also maintenance issues too. We shouldn't forget about 46% or so of implants, Pedersen 2011, have maintenance issues. So all of these issues, can be discussed, but you're asking me, and I'm the bias towards saving the tooth.
That's right.
But I think that the patient needs to, as best as possible, in these areas, which I call the gray areas, get all the options as unbiased as possible, as literature-based as possible. And then they need to decide themselves their own emotional and financial, emotional, all those things come into play here as well.
I agree. So we talk about the factors, and you rightfully mentioned about restorability is very important, isn't it? You want to make sure you can restore this tooth.
Yeah.
In the early days, the perfect end of it could not fix the tooth, and we realized, hang on a minute, we need to be able to have restoratively, and we'll talk about it in a minute. And then we want to look at the endodontic status, which is very important. We'll look at the periodontal status, okay? Well, we look at occlusion as well, and passion fractures and wishes. That's very important. Okay, patients to understand, what happens if you lose a tooth, what happens if you place an implant, and what happens if actually implant suddenly fails. Because we're taking a tooth out, you're promising a patient that the implant will work. Okay, And that's the consensus they're coming to you, because this is a good tooth. It's not a bad tooth. If you can save the tooth, I think we should advise the patient a chance to fix the tooth. I think the other thing I'd like to point out is that what else would I be thinking about? What else would I be thinking, for instance, in this particular case, besides all these 5 factors? And to me, when we talk about the implants and the maintenance issues, whenever a patient attends a practice and have a loose implant crown, you say you got a loose screw, which is great. But why is there a loose screw when you tighten an implant screw and there was an issue? So we need to find out the reason is the same reason that I will extrapolate to this tooth. I wanted to know, why was the restoration dislodged in the first place? So things happen for a reason. So instead of trying to find a quick solution, you need to find why. Why did this occur? And the reason why it occurred. Because patient ultimately is the only problem. If the patient is on the problem, it's your problem. And you know, you can say, well, look, you know what, look at this, there's bones about here, I can't get down there. How are you going to put it? I agree. We'll talk about it in a minute. But to me,
so sorry, Sarkis, there were 2 questions. I'd say one for you, one for me. The first question's, I think Nimesh asked, Nimesh Patel asked, if the crown becomes loose and a patient comes to us, when do you consider redoing the endodontic therapy? In any situation, I'd for sure be having a look at whether this tooth was exposed to saliva and recontamination. And look, in many of these cases, because if they're referred to me, I have to take the onus, I would always go ahead with retreatment despite whatever I see radiographically. Even if I don't see a lesion, to be honest, I'd rather put my stamp on it and had a look at the entire root canal system. In this case, there could be, if you take a 3D scan, a missed MB2 anyway. I'm not sure what's going on. I'll need a 3D scan of the post, you know, where they've probably placed the previous post. It just doesn't look quite right at that junction in the palatal root. So I'd like to see that, or to see if there's any evidence of any perforation, and you'd see them better with a 3D scan. So my response is yes, absolutely. Not only I'll be looking at cracks within the root and at the cervical area. Once you remove some root filling, you can see at least that better when you illuminate through the root structure. But in almost every single case or situation, I'll be attempting retreatment prior to sending it back to the dentist for a more expensive restoration over the top, a more definitive restoration. And the other questions for you, Sarkis, I think, biologic width and possible probable surgical crown lengthening of this case. So I'll leave that one to you. All
right, I'll be able to answer that in the next few slides. So I'm happy to talk to you about that.
Sure.
But I mean, the important question for me was, again, was dislodged. Patient did come with a crown and mouth. This is slightly loose, so it hasn't been loose for a long time. Probably he's very aware of it. But root therapy was done by endodontist overseas, which is, again, I cannot tell how, I mean, to me, it's looking at this stage, he was adamant hanging on to his teeth. He was offered to see an endodontist again, and his wishes said, look, I'll take on responsibility if you can restore this tooth, but I don't know it's down at the end of this for a long time, and I accept that, Mehdi. But
yeah, so I would probably always state this then to the patient, that's fine, no problem, as long as you know that in a case with like this where there's no lesion, and I agree with you, say an endodontist did a great job of it. If you want to talk real life and not textbook, like real life case, then I would always warn them 1 to 2 out of 10 will need retreatment or may flare up as soon as we put the brand new whatever, you know, restoration or the. So I would probably temporize these cases with a call for a longer period.
That's right. That's exactly what we did.
Yeah,
that's exactly what we did. Just to, again, you're testing your diagnosis. So when we talk about restorability, and naturally we'll look at the sound tooth structure, okay, the dentine, like at least a few millimeters of dentine present, and the thickness. Look at a core strength. Look at a pulp chamber. Mold's got a good pulp chamber. I think that's really important. That's the advantages. And also the root morphology. Now, Mehdi, we got a habit of placing sometimes amalgams in the pulp chamber. What's your gut feeling on that?
Yeah, I'm not a fan of amalgams in the pulp chamber. I think that there were two reasons for it, and I'm talking about studies way back in the late 80s and 90s. One of the studies that people quote is Hansen and Asmussen. That's a 97 study. And what they saw was the trend of the Nair core. And as soon as they started placing Nair core, they also saw a trend of cracks and fractures. One reason for amalgam, not in the pulp chamber, and so say, for example, not just the pulp chamber, but I'm talking about placed within the orifice of the root canal, like, you know, the exact Nair technique is use a slow speed burr, remove the gutta perca, about a mil or two, and pack the amalgam in. So one of them is that whole removal of pericervical dentine. That's the most critical dentine. That's where all the stress concentrations are. That's where endodontically we're trying to keep our tapers small. We don't want to go large taper. We don't want to do a Gates-Glidden prep of over a Gates-Glidden size 4 or 5 because you'll give yourself a bottleneck appearance. You remove too much cervical dentine, which is the critical part. That's where all the stress concentrations are when the tooth is in load. The second reason for amalgam, so apart from them using a slow speed and removing tooth structure unnecessarily, so it wasn't sort of just passively placing amalgam, it was actually like drilling tooth out to place the amalgam. Second reason was expansion of amalgam over time. So for those two reasons, they did see a trend between placement of Nair cores and more cracks that occur cervical to apical. So we talked to cracked teeth. Some more cracked teeth in the crown root level cracks, craze lines that run vertically down the root and they result in failure.
Interesting. You know, when we look back, when we graduated, that was the most common thing to place amalgam and build cores, if you remember, and how things have, you know, improved over the period of time. The other part is another status. We've talked about the MB2 and the root formation. What would you say about root formation here in terms of this resistance to stress? I mean, it's pretty well, you feel this can take a load, the root system, right?
Yeah, I would say that this is a better root morphology than a slender, more fused root anatomy. For example, an upper 7.
Yeah.
A lot of times you'd see it's a lot more fused root anatomy style. So those have got their root shape is not favorable. I also am looking at the mesial root here, and I think that the endodontists did a fairly good job of keeping the tapers small. One of the things about location of MB2 I like to add here, the shape of the mesial root is figure of 8. You need to be very conservative when you look for MB2 canals. I have found the trap of finding MB2 canals because I knew they're there in 90% or more of occasions and they're a reason for failure. But then the type of fractures you see are always that mesial root and they run down the MB2. So when you go down the microscope, you see your own failures like I have, and they usually happen between 18 months to 4 or 5 years onwards. And the patient that you don't expect in the waiting room, they've missed their recall and they're sitting there in the waiting room, you know, 2 years later, and you're like worried, you're like, they wouldn't be back otherwise, there must be something wrong. And often that upper 6 is where I have over-trephined to look for that MB2. So I knew the MB2 is important. I knew that'll come back and bite me, or maybe some teeth don't settle after not finding them. But at the same time, if you over-drill the mesial root of an upper molar or even a lower molar, over-trephine it, you know, over-trough it, looking for canals, looking for mid-mesials in the lowers, you can predispose the tooth to a vertical root fracture as well. So you've got to be, there's a balance between how much you trephine away and what you look for. So again, this is where, in many of these cases, like yours, this one here, for example, Sarkis, I may take a pre-op 3D scan because I'm worried about the palatal root and what's going on at the interface between the palatal root. You know, I'm just questioning whether the previous post was, you know, how much tooth was removed, was there a strip perf or something. But even if I don't do a 3D scan of it and I decide to retreat it, I will do a 3D scan when I start to look for the normal place or the usual place and MB2 canal is. So I'd usually take the scan after I've started to retreat the tooth like this, so I can look into things and maybe then be able to locate the MB2 canal if it's there more conservatively. So sometimes putting a radiopaque material like calcium hydroxide and showing where I've been trephining helps me locate that 3D scan. So in these cases, I don't maybe take a routine pre-op 3D scan. I take one during treatment to locate the canal that I can't find without trephining too much tooth away.
Mm-hmm. I see. The idea is not to weaken a core.
Correct.
I see. That's very important. It's funny how much thought process goes in just to something simple as person, core, and crown, doesn't it?
Yeah.
Okay, and there along the stuff that you do from your end, trying to make sure you maintain integrity of the root formation, the whole root integrity, root seal, the materials, the seal that you provide, and the crown as a seal. So something's happened here that's gone drastically wrong. I'm just going to divert a little bit to another case before we come back to this case. And Nimesh, I haven't forgotten your question, by the way. Thank you for that. This happened today. And the patient comes with an implant, and she's very concerned. She thought she needed an implant. She didn't want an implant. But it's quite interesting, isn't it? When you go, I was on the fracture, subgingival. Doesn't look too bad. If you can sort of, if you try very hard, maybe save this tooth. You can, if you need to.
Yeah. These days, I don't want to try that hard.
I know. As a patient,
yeah, I know what you mean, but I'm like, oh man, yeah. There are better options. But anyway, yeah, let's have a look at what you did.
You're so stressed, and so look, let me just put it back. So anyway, we managed to put this back.
Oh, you bonded the crown. That's good. Yeah.
I put it back in just to reduce the stress. I said, let me think. But seriously, patient tells me I need an implant, and I have a different question to ask. I say, well, I need a risk assessment, because one important aspect of it, that what I'm thinking at the moment is, it's not about talking about aesthetics, this section. We're going to concentrate on function, and we'll talk about the restorative design in this particular case. How complicated it is with everyone's doing reconstructive cosmetic work, especially on the anterior crowded dentition, and a lot of things needs to be considered here as well. So this is one of the biggest mistakes that I see in my daily practice is when the crowded, dentition being restored. This is 18 months ago. Patient had and the screws have been restored. I'm not going to comment about the integrity of the restorations. I won't go into that because it's not about that. But what my concern would be in this case is how we think we can just, reduce teeth and cut teeth down to make them look better, and at the same time reduce the integrity of the biological integrity of the tooth and predisposal, and let alone the tooth of previous root therapy has been heavily prepared. There's a lot of factors here. So the question was, what do we see? I mean, what do we see? I'm looking at a number of abstracts here, and my biggest concern is where do we go from this patient? Because if you're going to think about placing an implant here, maybe, I'd like to know the reason that this tooth fracture in the first place. I'd like to know if the same force that caused the fracture of this tooth will also act on the implant. So you're going to get a regular crown loosening and screw, crown loosening, the abutment screw loosening because of the same forces. But also the fact that we've got a live patient who's extremely distressed. So we're going to restore the correction of anterior teeth. The occlusion is incorrect prescription because this tooth is loading. That's why it fractured. The restored design has compromised this patient's dentition for life, and she's only at the age of 35, and 18 months of this release being completed. And I'm looking a bit more here, and it's obviously need more risk assessment. You can see that a lot of the time, I mean, about risk assessment, I looked up the dictionary and it says the area risk assessors proceed, evaluate hazards, and then remove that hazard or minimize level risk by taking control measures as necessary. By doing so, you create a safer and healthy environment. And I think we need to look at these factors so that the treatment that we plan for our patients will be able to be, maintained by the patient. So you can obviously see that the original crown is being heavily loaded during protrusion, and patients have bruxed. Now this was taken into account. So teeth were restored to make them look good. There's other factors here, but the problem is there is no protective occlusion in this patient. An occlusion is dynamic, it's not static. There's no static occlusion. Occlusion is very dynamic. And how do you feel about here from your end, maybe when you're seeing this sort of patients after the root therapy?
Yeah, day in, day out these days. Initially endodontists, I've worked with obviously prosthodontists like yourself and others. So I see the full picture. We don't just look at the endodontic factors, for example, but it's easy just to do endodontic therapy on a tooth and rubber dam it and send it back to the dentist. But these days, one thing I do, and I've learned that from you, Sarkis, get them to bite. You do the excursive movements, have a look at the bite, have a look at Kray's lines, transilluminate these teeth, and have a look at what the anteriors are doing here. For example, the lower anterior being slightly more protruded, probably as a result, and excessive forces on that upper anterior, which was weaker, has resulted in a catastrophic fracture. So I always look at the bite. As an endodontist, I always look at Kray's lines and what the bite's doing and wear facets before I even jump in and do any treatment.
Maybe one of the easiest things to do, not everyone's got a microscope, but you can easily take a really good camera shot and blow up on a big screen. You can see so much. And so I'm here in my consulting room, I call it mission control. And people usually come, patient comes, sits here and look at their mouth right here. So they can understand what I'm talking about. When they're laying down, they never understand completely, they never get it. And in this particular case, it's quite obvious that the patient's loading. And not only the loading, coming back to the same, philosophy of treatment, stabilize the control phase. No matter what you do, you have to control the forces. Test your diagnosis. Okay, understand, when you measure that, you would like to have a long-term post and core, right? Because you're not sure about root therapy. Well, you want that before you talk about definite treatment and reassessment, okay, maintenance. And in many ways, the maintenance starts at initial visit. Patient has to understand and comprehend the whole thing. It's a very integral part of it, of this case, to be able to allow the patients to look, if I'm going to have this work done, they're all trying to help me, I need to be committed to regular maintenance review. And having said what I did for that particular patient, I temporized, I reassessed patient factors, compliance, function, did a temporary crown dislodge. I will wait and see. The oral hygiene is a lot of work. Test vital the rest of the teeth and probably send the patient to have a look at the rest of the teeth for me. Periodal charting, occlusion, okay? And most importantly, we'll talk in a minute, is consider reorganized occlusion, because the patient would have really benefited from orthodontic treatment, and they should give that option in this particular case. So restorative correction, where they unnecessarily ground all those teeth with the sagittal veneer, constricted the actual occlusion, so the patient was locked in. And the only release wasn't up front tooth, it's just, Tejan talks about 984 pinpoint interferences. You just get in there and they just snaps the whole tooth. And again, it's important to understand, how do we want to look at these patients? Well, in real sense, when we think about this, this is what the patient does. The tooth fractured by jiggling forces. She brings it in, locks it anteriorly, okay, and then brings it back and then pushes forward, brings it back, and that's the only tooth that's actually contacting in the arch. Now, it's interesting to see that all this work was done, but hardly any attention was paid to the dynamics of the occlusion. Okay, so I think we should learn from this, and in terms of looking at the occlusion, as you said rightfully, Maddie, is reduce the forces, just like anything. If a joint pain, you reduce the load on your joints. Tooth is same, to reduce the load, allow it to recover, reassess. And that's how we need to look at things. So risk assessment. Then we talk about the posts. Do we need posts? I think there's a lot needs to be said here. I know that you know, this sort of situation, unfortunately, I'm stuck with what I have, but no one have a really thin cylindrical parallel post that will just go back and have a core attached to it. So that's actually, this is a very passive post that fits there. You can see how well it's fitting there, okay? So one of the things about posts is that it doesn't reinforce the tooth, it just retains the core. There's a core, there's a post, there's the actual tooth core, okay? And crowning of the anterior teeth doesn't really improve the longevity of the teeth either. It actually can weaken it many times. So there's only excess cavity, as we agreed, Maddie. You just
yes. Yeah, with incisors and laterals, especially laterals, leave your access cavity in your mesial restoration or your distal restoration. Do not strip away the lateral, because you'll definitely have to put a post in the middle, and the most catastrophic failures are coming from laterals that have been over-treated, so crowned when they didn't really need a crown and had a post in it.
100%, 100%. All molds improve a better full coverage crown due to vertical forces. Next to the anterior teeth is angular forces. So how do we plan our restorations? So we need to think about those things. You know, and with root therapy, team reconstruction significantly, you know, we can resistance to fracture. I think the most important thing that post will help is, you know, does improve resistance, you know, in many ways. If it's passively fitted, it's got a passive fitting post. That's been very passive. Now, how do we define passivity? You want to comment on that, maybe?
You know, essentially, whatever post that you're placing needs to not be a snug, especially with, I'm talking here about cast posts. You don't want it to be snug fit. You don't want it to fit within the cavity, and then you're finding it difficult to remove. So many of these posts, what you want to do is to drill around the post core interface, so they fit in without any sort of a very easy path of insertion and removal, loosely fitting, if you like, and your cement acts as the cushion. Many of these cements these days are resin bonded cements, Relay X and Maxim, Panavia, and these cements act like the cushion to redistribute the stress rather than the stress from the snug fitting hard cast post or rigid cast post going directly into the root structure. The other thing about a passive post is you just remove or heat out gutta perca. You don't need to drill away peri-cervical or any dentine for that matter within the root structure. So we talk about a post that's thinner in diameter, that because of those two reasons. It's passive fit, and you don't have to remove any dentine to place it or to take an impression of it if you're making a cast post.
That's right. If the callers get noticed, this is a special copper plated die, and the die is probably right to the post length all along there. And the way I test passivity here, the cast is, because I need the strength here, I just invert the whole thing down. I just tap it slightly. As it drops, to me that's passive. Try in the mouth, never force the post, just gonna go gently. If it doesn't, don't push it. I rather, you know, you don't want to bind it. You just want to just gently dropping in there. I'm using phosphate, but I accept the fact that, you know, all the other resistance are fine. I've been using zinc phosphate for this sort of post for a long time, and there's a lot of data on that as well, and I agree with you. Now, I think that we should also say that they should consider the fact it's effective resistance of root fractures, such as, you know, what the occlusion, the importance of, for instance, how much force is there, the duration of force. I think the magnitude of force is very important, because it's not just force at that point of time, the duration is very important. And maybe look at, for instance,
Yeah, I'll be also looking at flaticles or planes on previously weakened endo-treated teeth like this one. And as you said yourself, managed occlusion with also long-term maintenance and adjustment, like we adjust implants or maintain implants. We should be definitely maintaining the crown you place on this tooth with regular, 6 monthly to a year adjustments according to the dynamics of the occlusion, as you said.
Very, very important. The anterior tooth was continually adjusted, although restorative design was quite incorrect, but nevertheless, there would be less likelihood of fracture, maybe patient.
Yeah. Sorry, Sarkis. We'll come on to William Cross's question on, probable surgical crown lengthening and everything shortly, because I know the punchline is coming.
Yeah.
With your presentation, Sarkis. But there was a question from Dr. Ravi. What is the preferred post system, the cast post or fiber post, question mark?
We were waiting for that.
Yeah, we're waiting for that question, yeah.
Well, let me answer the question in a minute. I'll be happy to talk about it. Let's talk about the cast post. This is a very old study. Provided you have a passive post, and provided you manage occlusion very well, and provided you don't undermine the core dentine that supports the strength of the teeth, there's a longevity of this teeth that lasts very, very well. I'm choosing an older study, and there's a newer study where although cast posts, when there's a fracture, is catastrophic, and in terms of fiber posts, you're able to have another go. But the trouble is that most of the time, teeth are so destroyed that you can't reinforce it. So, I think if I'm looking at the tooth, there's got adequate, at least 3 walls. I'm happy to place a fiber post if I can get away with it. But if there's a less walls remaining, I think cast post would be the choice for me at all times.
I totally agree. So if there's more than 3 walls remaining, maybe a fiber post, or in the area where the occlusion is quite heavy, I still prefer a parallel-sided rigid post.
Yes.
But when you've lost more structure, like this case here, you've got to go for a cast post, because many of these fiber posts will just snap. And by the time they snap, there's been so much leakage around them. And by the time you remove them, there's even less tooth left.
Nothing left. And that comes to the next slide, where is it beneficial to have post, because the selling point of the fiber post, Ravi, was the fact that they have the same modulus of elasticity as the dentine. They flex more. The problem is that flexing can reduce stress, but you also move in the core in a heavy occlusion with minimal tooth remaining. The whole is going to break. The idea is to maintain core dentine, and you want a thinner post with a greater modulus of elasticity. This is why cast cylindrical posts with a core with passive fit will really help the situation. Would you agree with that, Matt?
I totally agree. Fiber posts might be good in patients that are not like edge-to-edge bite, or not like the other case you showed where there's a protrusive low incisor. Fiber posts might be good for most other, if necessary, and these teeth need a post, bored out cervically anterior teeth. But for maybe for some premolars as well, like upper 4s, fiber posts are indicated. But when you come to molars, where a lot of the heavy occlusion is upper 7s, upper 6s, lower 6s, lower 7s, and as you said yourself, more than 3 walls are missing. I think that definitely, there's without a doubt, you want something that's more rigid, like a cast post, or even a parallel-sided thin metal post will be better than a fiber post.
We're coming to your answer, Ravi, very soon. End of the next. So the problem is, really, so how do we, to restore, to remove? That's a question, okay? And having said that, if you're going to restore this tooth, okay, how do we restore it without reducing the bulk of the tooth structure? So that's a very question to ask, and I think Nimesh is waiting for an answer, because he knows this is where it's going to go. I understand that. And this is something that if you did, any of the polycrystalline ceramics, such as zirconia, you're going to cut at least, 0.8 millimeter to get that strength of the crown to hold, and that's going to reduce it even more. And I need something really a lot smaller than that. So, you know, we increase the bulk of the tooth structure, we understand that. But can we build a core? We did. I mean, is this adequate? You know, and you can understand one thing, that's sorry about the spelling there, but molar acidic teeth, they will reduce proprioception, okay? And mainly the periodontal mechanoreceptors are holding, you know, giving you the strength. So in other words, they can take a lot more load before the protective mechanisms come into play, okay? They're only sensitive to mainly vertical forces, while your anterior teeth are sensitive to lateral forces too. When you want to test, like with an eggshell, you always touch your anterior teeth because it gives you the best sensation, best proprioception. For incising, there's a concept of central pattern generator, which is the motor of the masticator system in the midbrain. So those factors we need to think about. Another factor that comes into question is that force, time, and magnitude. How long this force is going to be there? The magnitude of the forces. So it's important. You can't expect people to wear night guard if your restorative design and your occlusion prescription is incorrect. Okay, because they're not going to wear a night guard. It's extremely important to understand that you don't tell the patient, well, you didn't wear a night guard, that's why your tooth fractured. That's not wrong. It doesn't work that way. Okay. Okay, you use night guard because you know they're brushing at night, they're doing this, but if you're doing a lot of reconstructive work, you need to choose the right materials, right occlusion prescription, and continual refinement of occlusion to redistribute forces and reduce pinpoint interferences. So the question, if to restore, how do you go from here to there? Now, you notice that there's a bit of space here because that's exactly where I'm happy to post to, and there's actually filler material here. We do want to open this up to weaken the root structure. But we build up adequate core, and you can see how far I'm inside the biologic width. And I've totally violated the biologic width.
So this is William Cross asking the question, crown lengthening, no need with what Sarkis has done here. He's just violated the biologic width with a beautiful gold bevel. That's right.
So violate biologic width. Crown lengthening, William, here would be, and I understand, you see, it's been explained that you need to create adequate core, but I can, in the college, we teach how to gain more of a tooth structure. You know, let's talk about biologic width, okay? In the early 60s, even in the 50s, Walter Hart talked about biologic width, Linda talked about biologic width, and what's the name of the other chap? Gargiulo talks about biologic width as being, you know, certain dimensions up to 3 millimeters, but it ranges. Just remember one thing, that when we talk about the specific measurements of biologic width, which is 1.4 and 0.94 and 0.6, whatever, it's not about those numbers, because those numbers are averages of averages. Biologic width changes between patients, in the patient, between position of the teeth, within the tooth, within the arch. So you need to measure it, each tooth separately, to decide how far I can go down. Having said that, there's a preparation techniques that I can easily slice into the area and gain impression. And I mean, you know, this sort of fit of the crown is, you know, it's a definite fit. This crown snaps it. It's about 2.5 millimeters of gold all around it that grabs the core of the tooth. Okay, that is the most important part of the you know, restorative asserted resistance to this, to reduce the fracture of this tooth. Naturally, flat occlusion is extremely important. But so from my point of view, if you can place the crown deep, which is like within 3 millimeters, into the violation of biologic width area, I haven't violated, I think that's a misnomer in this particular area. I will do the same thing to the anterior tooth and have no problems, and I have a lot of data on this. There's a good research on this from Terry Walton. He's got over 15-year data on this. And the most important part of it is that a type of cement to use. So if you're using a resin-based cement, there's no way you're going to take the cement out. You will actually violate biologic width. But using a natural cement, zinc phosphate cement. It'll flick off. There'll be minimal problems because you can get in there and clean that out and just flick that off. Because the important thing here is that you want to, restore without reducing bulk or tooth structure. And to do that, you need metal, you need high-grade gold. Okay, 30 microns. These 30 microns will go straight up to 3 millimeters into and grab that root without image. You can see how thick that is, okay, on the palatal aspect. Why palatal aspect is thick? Because that's where the fracture was. Okay, I was able to go inside and grab that root to be able to reinforce. You see, the tooth, the crown has to go and reinforce that, get that ferrule past the core. So it's not, if you try to place the core and your crown sitting on the core, you're just inducing greater amount of stress onto the post root system. Okay, you're not getting the coronoapical stabilization and complex formations. The whole thing moves as one. Okay, it's very important. So if it happens, if the crown's sitting on top of the core and the core is attached to the tooth, it's actually tipping here. So the fracture happens right there, and the whole there's a fracture of the tooth. So it's important to have the margins of the actual crown in this complex root fractures where you're restoring it, is to go past about at least 2 to 3 millimeters to grab that central core that you provide resistance to the fracture of these teeth. And having said that, you can see that's 3 millimeters way below. Okay, that's 6 months past, and I can't see any violation of biologic weight.
And I've noticed also, I think, Sarkis, here, you've kept the palatal cusp quite flat there, haven't you, on purpose?
Absolutely. You can see that this is high and this is low. It's a bounded tooth, reduced stress. This is completely clear. Okay, and root therapy teeth don't erupt the way the normal teeth erupt, do they? So you clear the occlusion and just maintain nice central complex in the whole. There's a clamping down, just like you would do on implants. It's not different. Okay.
So I'll make one more comment. I don't know if you agree with this one, but if I'm seeing no signs of bruxism here on other adjacent teeth, like very little, if any, wear facets. But if the patient was a bruxer, I'll probably one thing I would recommend or change with your design is that just to reinforce it even more is probably a gold palatal lingual surface. Would you agree on that?
100%. And that would be my favorite too. Again, passion factors dominated.
Yeah. So more malleable material, definitely non-zirconia, definitely non-hard Emax style. It has to be. I'd rather have porcelain that chips here.
I would rather have. I would normally have this particular patients. Here's a bit of a clencher. It's not so bruxed, but I would have gold covering all around here on the edges.
Yep.
Gold. Okay. If that would be my complete preference in this particular case. And on a more note, if you look very carefully, as a conclusion, you just can't mill it. You need to make it. You need to make it to get the important, 30 microns here. And if for me to get into that biologic width area, I will just really trim it. I will take an X-ray just to make sure that it just slides into that area, and the zinc phosphate just flake off. Then we gold plated, polish it, gold plated, and that's how we get really good fitting restorations. You just can't get better fit than this.
That's beautiful work, Sarkis. Beautiful.
Thank you. You just can't build it, so you need to make it. You can't mill this. Okay. Now we can maybe we can mill the wax pattern, which we do, but this could be cast done properly in advanced technical care, and and it does cost again. So well, we can take it out and the same cost and put the implant in. I agree. I'm not saying I disagree, but one thing that's very important to understand, the question to ask in the conclusion of the lecture is that implants do work, but also implants fail. They fail. So what next? What about if you place the implant and it failed? Where do you go from there? At least the patient feels comfortable. Okay, at least the patient's comfortable that you spend the time, although they paid for it, but they understand that you do the best thing for them. Okay, you try to save their tooth. Because if we convince the patient that we're going to take this tooth out, and you could really be safe. In their mind, they will think otherwise. I can assure you, sometimes that will dominate their thought process far more than what we logically think from our end, because this, after all, is their tooth, their body, and it's about, the right question is to ask is, what's the biological and financial cost when we lose a tooth? And that's something that's very important to understand as the conclusion of today's seminar or webinar, is talk to the patients, give them the option, give them your opinion, and give them the rationale why you think that way. So sometimes, when I'm talking to colleagues, I say, look, I've got your patient here. The question I'll ask, not what went wrong. I said, just tell me rationale, why did you do it this way? In that way, I'll be able to understand with the way my colleagues are thinking, then I can talk to the patient and sort things out quickly and get a quick resolution and just get on with people's life in their treatment plan. Well, thank you very much. Any questions? It was a good discussion, wasn't it, Eddie?
Yeah, it was good. It went well, I thought. Yeah, add to this, like, just give the tooth another chance. Many people just come up with a blatant, oh, let's just pull it out. If the patient's willing, if there's financial means and they're willing to give the tooth a chance, with the right restorative plan, and of course, endodontic assessment, periodontal assessment for that tooth, I just think it doesn't hurt to give the tooth another chance, because you've always, as I said, got the implant backup option, but also remember, when implants fail miserably wrong, they fail miserably wrong, and then you're left with very little option to manage some of those cases.
A huge defect.
Yeah, just give the tooth one last chance, guys. At least, only if the patient's willing. If it's a difficult patient, I'd rather have them have them go for the implant any day.
Exactly.
So watch out for the red flags, of course. If you're discussing everything and you realize, oh, they're really all about finance, then sometimes it's not worth it in the compromised cases, because then it'll come back and bite you at the same token. But if they're willing to do it and they understand your philosophy behind why you're saving the tooth, low sinus, like this case, there was adequate structure, and Sarkis was cleverly able to gain more ferrule subgingivally, supracrestally, and that 2-3 millimeters meant that you're really wrapping the tooth, and you chose the right material over the top of the endo treated tooth. I think all of those things mean, if the patient's willing, you always give them a chance. Especially as Sarkis said at the beginning, this patient's in their 40s, late 30s, 40s. They're not even 50. What do you think will happen 10 years later when they've had all those potential maintenance issues, and some of them might have been failures, implant-wise?
And there are situations where people can't have implants. They're on the anti-resorptive medication.
Yeah.
I mean, what do? You're going to find a solution. And, it's important to accept that. And I agree with you, Mehdi, when you said the difficult patient just give an implant, as long as they're on the problem.
Yeah, I guess that the difficult patient, when I send you, you'll probably see the red flags, and you'll probably palm them back to me saying, no, save the tooth.
Well, they're on the problem that you have to help. If the patient says, fix my problem, the answer is can't do it. Can't do it. And nothing's right. Thank you, Mehdi. Any questions?
Thank you.
From my colleagues?
All 21 are still there, but it doesn't look like, questions.
It's been a thought-provoking webinar, Mehdi. I think I always like those webinars because you start thinking about things. And
thank you very much.
My assistant dentist, Dr. Natasha, she said to me, he says, I'm starting to think like you sometimes, so it's fantastic, and I'm sure she's listening. But
give these patients extra time. That's all I say. Like these ones where you had the upper six, as you said, sit them aside, give them extra time.
And
because you went through all the risks. You spoke about everything at the start. You assessed everything before you delivered the potential, treatment options. Of course, you choosing this one in your mind. You saw, everything beforehand. and you saw all the potential, you discussed all the potential possible complications later as well. And I think that way you can give that as a tooth a chance if the patient's reasonable.
Thank you. Dr. Nimesh, have we answered your question?
Yes, Dr. Sarkis. I'm all good.
Thank you. Any other questions?
Not so far. I mean, I just shared a case with you last week about the short implant, Well, that case was very typical when I won't take the names, but there was a dentist who probably just had simply a root caries, not even in the root, it's just on the cervical margin. And they decided to take a tooth out and place a dental implant where there was a ample of the bone support, root support, everything. But they took the tooth out and placed implants, and I don't think that was the right decision to make. Patient is in the late 50s and high occlusal stress, high occlusal forces. That's not going to disappear suddenly by placing an implant.
True. Patient, I think that things will come undone unfortunately, if the implant does fail, then we have a problem. So, hopefully it works out, it'll be good. That sort of thing. Okay. I think if there's any other questions, please let me know. I'm happy to answer. Any question that you talk about crown lengthening, this particular patient, implant would be definitely an idea. I think many agree this is more of a case for an implant.
Yes.
But I mean, would any of my colleagues like to comment on this? What would you do before the implant? I think I would do something else with the implant for this particular patient, because see, one of the complex aspects of implant dentistry here is that once you do an implant, you lock that bone in that position. So that bone is not going to remodel. That's it. It stays there. So patients should be given the option of orthodontic care. So even making a small temporary and giving all the orthodontic appliances, you can do a lot of things with this patient. So the options there, people should know, and then they make the right decision for themselves. That's what I'm saying. Give the patient an option. Very important. Very important. So if the patient can see their mouth from this end, it'll be very interesting to see what their opinion would be. Then we are seeing their mouth from your end, and that's important. Any questions before we say goodbye to each other?
Everyone wants to go to bed.
Well, thank you so much, Mehdi. Thank you.
Thank you. Cheers, guys.
Yeah, thank you.
Thank you, Mehdi.
Thank you,
Nice, nice, pleasure.
Thank you. All the best. Thank you. Thanks, Mehdi.
Thanks, mate. Cheers. Catch you later.
My love to your wife, your little ones. See you.
Thank you. We'll do. Cheers. Take care.
मैं क्या सोचती थी पता नहीं मुझे लगता है मैं सोचती है